In the last lesson, we covered the foundational information about our 12-lead EKG. Having that understanding out of the way, we can now move into the actual interpretation of the EKG itself. I'm going to break down the various aspects of interpretation into really several videos to be able to cover each part in more detail, but in this lesson, we're going to review over the overall steps that are involved in our 12-lead EKG interpretation. Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Now also, if you do enjoy these lessons and you'd be interested in getting CE credits for following along with them, then head on over to icuadvantage.com/academy and join the ICU Advantage Academy, where you can watch all these videos. You'll have access to all the notes, including the new notes that I'm currently working on updating, as well as audio-only versions of these lessons. And most importantly, you'll be able to actually earn CE credits for participating in this education. So I've got some great deals going on over there, so make sure and check that out. Now, if you would like to support the channel but really don't have a need for the CEs, or if you just want access to things like the notes, then you might also want to take a look at either the YouTube or Patreon memberships. Again, links to both of those, all that stuff is going to be down in the description below. Alright, so this lesson here is going to be an overview of each of the steps of the 12-lead EKG interpretation. So when we get started with reading EKGs, it's really important that you identify some sort of systematic approach that works for you and that you can go through each and every time. Now, really the purpose of this is to ensure that you're going through each EKG thoroughly and that you really don't want to miss any of the steps. There's a lot going on with our 12-lead EKG and there's a lot for you to evaluate, so I really want to make sure that you don't get lost in all this information. Now, more advanced practitioners are not necessarily going to follow a step-by-step process, but they've done them more than enough that they really know what they're looking for and they're not going to miss any of those parts. That said, it's really best to find a systematic approach for yourself, and at least for some period of time initially, you want to religiously stick to it. This way, you're going to ensure that you're evaluating every part of the EKG that you should be. Now, all that said, as time goes on, certain obvious things will begin to stick out to you, but other than some circumstances where you need to make a quick decision, such as if you're giving nitro for a patient that has chest pain, etc., you're really going to want to stick to this systematic approach, this stepwise approach. Now, there are many different approaches that I've seen, and they all cover the same information, just in different ways of going about it. So here, I'm simply going to be presenting one approach that I found helpful. Alright, so into our 12-lead EKG interpretation. So as we go through the steps of our EKG interpretation, we're going to use a normal EKG for this process. So right here is actually an example of a normal EKG that we're going to primarily use throughout this particular lesson. So it is important that you see normal. Knowing normal is going to help you identify when something isn't normal. And particularly in the ICU, we're seeing sick people, elderly people, and they just aren't completely normal. So it's really helpful to be able to recognize a good normal EKG. Alright, so to start things off, we've got our first step, which is going to be our rhythm analysis. So for this step, it's going to be expected that you've got a good understanding of basic rhythm interpretation. So I'm really not going to be covering that in this lesson here. I will actually link to a series of lessons that I've already put together covering all these different topics, all the blocks and all the different rhythms that you're going to need to know. Watch that lesson if you certainly aren't comfortable with that stuff. But when it comes to our rhythm analysis, first we want to actually determine the regularity. So we want to determine if the rhythm is regular, regularly irregular, or irregularly irregular. If we have consistent intervals between our R waves, then we obviously have a regular rhythm. One of the easiest ways to check for this is if you got a piece of paper, put the paper on the EKG, make marks on 2 of the successive R waves, and then just move that paper along and see if those R waves just march right out. Also, just at a quick glance, oftentimes an irregular rhythm is really going to stand out, and you'll really be able to see the differences in the R to R intervals. So here's actually a quick example of an EKG of a patient who's in AFib, and as you can see here, especially if we look down at the rhythm strip across the bottom, it's pretty clear that we've got some pretty inconsistent R to R intervals. Now, keep in mind that just because our patient's rhythm is regular, it does not mean that the rhythm is normal necessarily. We can actually see regular rhythms with a flutter, third-degree heart block, junctional and ventricular rhythms, just to name a few. Now, if the rhythm is not regular, but we do see a consistent pattern to some of this irregularity, then this is what we refer to as regularly irregular. So some examples of this would be things like potentially atrial flutter sometimes, second-degree type 1 heart block, so our Winky block, as well as bigeminy and trigeminy. These are going to be irregular, but there's going to be some sort of regular pattern to this irregularity of R to R intervals. Now, if the rhythm is not regular and there's really no discernible pattern and the QRSs just seem to randomly appear at different intervals, then this is what we refer to as irregularly irregular. So some examples here would be our sinus arrhythmia, atrial fibrillation, atrial flutter can sometimes present this way, multifocal atrial tachycardia, and this is really where we have multiple areas of the atria that are firing, as well as our second-degree type 2 heart blocks. Now, from there, once we determine the regularity, we actually want to move on and look at the rate. So we need to evaluate the rate of our patient's rhythm. Are they tachycardic, bradycardic, or normal? So remember our normal heart rate, 60 to 100 beats per minute. And so actually, if you look at the top of our 12-lead EKG, right here, the computer is actually going to show us a heart rate. But we also want to confirm everything that the computer tells us. This includes all of our other measurements, any interpretation. We want to confirm all of that with our own eyes and basically determine whether or not we agree with what it's saying. The computer is certainly great at giving us a lot of good information, but it sometimes can be inaccurate or just not sure of exactly what it's seeing. So there's several methods that we can use to evaluate a patient's heart rate. So the first one is we have our big box method, and this is probably the quickest and most preferred method, at least for our regular rhythms, but it does require a little bit of memorization or basic math. So with this method, what we're going to see is how many big boxes present between R waves. So first we need to find an R wave that lines up with one of our big boxes. So here's one here, so let's actually zoom in and take a little bit of a closer look at this one. So we know from our previous lesson that a big box is 0.2 seconds. Thus, it takes 5 of these big boxes to be 1 second. So if we kind of think about this, if we had a beat that was every 1 second, then in 1 minute we'd have 60 beats since we have 60 seconds in a minute, thus giving us a heart rate of 60 beats per minute. So knowing this, we know that 1 second is 5 big boxes, so if the next beat that comes along aligns with the 5th big box, we know that we have a heart rate of 60. So we can actually use this math to extrapolate out for all the other 0.2 second intervals, so each big box, and we come up with the following scale. So basically this is from 1 big box, 2 big boxes, 3 big boxes, etc. And so if the next R wave that were to come along were to fall on either the first big box or then the second big box, we would have the following heart rates: 300, 150, 100, 75, here's that 60, 50, 42, etc. So this is something that you can just train to memory, and then this way you can just look at an EKG, align these boxes, and then figure out what our patient's heart rate is. If you don't want to memorize, you can also do just a little bit of math. Essentially, you just take 300 and divide it by the number of big boxes. It really comes out to be the same thing. So to use this big box method, all we need to do is determine how many big boxes are between the R wave that we identify that falls on the line and then the next R wave. So in our example here, we can see that the next R wave is just before the 4th big box. We know that 4 big boxes would give us a heart rate of 75, so we know that we're just faster than 75. And as we can see, the computer here says 77, so we agree with this and we know that it's correct. All right, the next method beyond the big box method is to either look at a 6 or 10 second strip. So remember that the bottom of our 12 lead EKG has our rhythm lead that runs the full length. There may or may not be hash marks. If there are, they're going to give us 2 3-second intervals, so a 6-second strip as well as a final 4-second interval. This then gives us a total strip of 10 seconds. If there are no hash marks, then we just know that this total strip is still 10 seconds. So what we can do here is we can count the number of QRS complexes in either a 6-second interval and multiply that by 10 to get our heart rate, or we can count the total number of QRS complexes across the whole rhythm strip, so our 10-second strip, and then multiply that by 6 to get our heart rate. Now this one takes a little bit of time, but it's not too much more. And important to know that this is the method that we want to use if we have an irregular rhythm. So again, if we take a look at our EKG of the patient in AFib, so if we count across the bottom here, we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. We have 18 QRS complexes. We then multiply that number by 6, giving us a rate of 108. So now that we've evaluated the regularity as well as the rate of our patient's rhythm, we now want to determine whether we have a narrow or wide QRS. So again, remember that a normal here is going to be less than 0.12 seconds or 3 small boxes. So some common causes of having a wide QRS complex result from things like bundle branch blocks, beats that are originating in the ventricles, left ventricle hypertrophy, as well as pacemakers. There are some other less common causes, such as various drugs, especially some of our antiarrhythmics, our Wolff-Parkinson-White pattern, as well as profound hypokalemia. Again, in our example here, it's a little hard to tell, but we are less than 3 boxes, a little bit over 2. And here we can see the computer is telling us that the QRS is 0.084 seconds, and 2 small boxes is 0.08 seconds. So again, we also agree with this here. All right, now we want to move on and evaluate atrial activity. So first off, we want to see if we have P waves that are present. If not, we want to evaluate for fib or flutter waves. Now, if we do have P waves that are present, we want to look at our PR interval. Normal for this is going to be 0.12 to 0.2 seconds or 3 to 5 little boxes. We also want to evaluate, is the PR interval consistent or is it changing? And do we have one P wave for every QRS complex? If we don't, is there any association that's present between our P waves and our QRS complexes? So again, in our example here, as you can see, we do have a P wave for each of our QRS complexes. And if we look at this particular one here, we have about 4 small boxes from the start of the P wave to the start of the QRS complex. 4 small boxes equals 0.16 seconds. And once again, if we look up top, the computer is telling us it's 0.162 seconds. So again, we also agree with this. Now then, we also want to look at the size of our P waves and determine, are they similar morphology, as well as if there's any atrial enlargement, which I may actually do a separate lesson on, just covering some of these atrial changes. Again, in our example here, all the P waves look the same in each respective lead. And so finally, after going through all of these steps, with all the above information that we gathered, having the knowledge of the different rhythms that you should expect to see and be expected to know, you should be able to make a determination of the actual rhythm that's seen. So in our normal example here, we obviously have a normal sinus rhythm, which again, here the computer has also determined at the top, which once again, we can also agree with. All right, now moving on to step 2, here is where we're going to be looking at the QRS axis and morphology. So for our next step, we're going to want to evaluate both the cardiac axis as well as the morphology of our different QRS complexes. So let's start off talking about axis determination. And this is the part of the 12-lead EKG interpretation where people's eyes tend to just gloss over, or they get that deer in the headlights look. I'm actually going to do a whole separate lesson on this in much more detail, but it's really not that difficult of a concept to understand, I think, if it's explained properly. So basically, our axis is the average direction in which electrical activity flows through the heart when we're looking at the patient in that vertical or frontal plane. So we know if we look at our patient and their heart that the general direction for electrical activity is to flow down and towards the patient left, our right when we're looking at it. We have different parts of the heart depolarizing going in different directions, but if we average all these different directions of all of this electrical activity, and also with the left ventricle being the largest, we get an average direction. So this is generally from the patient's right shoulder to their left leg direction, which if you remember correlates with lead 2. So remember from that last lesson that we're going to see a positive waveform if we're moving towards a positive electrode, thus we expect to see lead 2 positive. So knowing that, we can look at the direction of electrical activity in relation to various leads to try and determine if we see positive, negative, or biphasic waveforms on our EKG tracing. Then we can actually use this knowledge to determine the direction of our patient's electrical activity, aka their axis. So if we look at particular leads in a normal heart with normal electrical conduction, we would expect to see positive QRSs in leads 1, 2, and 3. Again, in our example here, we do have positive QRS complexes in each of these leads. So there are several methods to determine this axis, which I am going to discuss in that lesson specifically covering all this. Essentially, we can take a circle, draw out different quadrants to represent the different axes, and we can think of these quadrants as the average direction of electrical activity. So in the bottom right, from 0 to 90 degrees, we have our normal axis. And just looking at this, we can see if we place this over our heart, this aligns with the direction we expect electrical activity to flow. Now above that, from 0 to negative 90, we have our left axis deviation. Although from 0 to negative 30, the first part here, we actually consider this non-pathologic. And again, I'll cover this more in the future lesson. Then in the bottom left, from 90 to 180 degrees, we have our right axis deviation. And then finally, top left, from negative 180 to negative 90, we have our extreme axis deviation. So there are different etiologies that our patient can have that deviate or shift this axis either left or right, which we want to be able to identify on the EKG for further evaluation. Again, this is all going to be covered in this lesson on axis determination. So for our example here, the computer gives us a QRS axis of 54 degrees, which looking at our quadrants we know is in that 0 to 90 degree quadrant, making this a normal axis, which we also confirmed seeing positive leads in 1, 2, and 3. Again, I know this probably sounds like a lot, but I promise it's going to make much more sense after that particular lesson on this topic. Alright, so after determining the axis, we then want to evaluate the QRS morphology, as this can really tell us a lot here. So first, if they have a wide QRS, we really want to determine the cause. Is this a bundle branch block or some other conduction delay? I'm also going to be doing a whole separate lesson on bundle branch blocks and how we identify those. But we also want to look for pathologic Q waves, and these are going to be Q waves that are present where we shouldn't see them, or in ways that are not to be expected, such as wider or deeper than normal. These are often a sign of prior or old MIs, and they usually take several hours or days to develop. Unless quickly revascularized, once they appear, they're typically not going to go away. Now, I'm really not going to cover this much in this lesson here, as this gets a bit deeper into EKG interpretation than I really wish to go here. But certainly feel free to look more into this, as it will help to further your knowledge of EKG interpretation. Now here we also want to look for evidence of either left ventricle hypertrophy or right ventricle hypertrophy. Again, this is going to be another separate lesson that I'm going to do, but essentially we're looking for enlarged QRS complexes in particular leads that can be an indication of enlarged ventricles. We also want to evaluate low voltage, and this would be small QRS complexes across the whole EKG. And this is actually caused by conditions that would limit the conduction of cardiac electrical activity to the surface of the skin, which is where we measure it. This is typically caused by either fat, fluid, or air. Here's just a quick example of a low voltage EKG. As you can see, the waveforms are really not showing very big or defined, and we're seeing this pretty much across the whole EKG. So some of our common causes that we see for this are going to be things like obesity, where here we've got fat that's getting in the way, COPD, this is going to be air that's interfering with this conduction, either pleural or pericardial effusions. This would be fluid, as well as myocardial infiltration. Again, another source of fluid that's going to potentially block that electrical activity, that conduction of electricity from going all the way out to the skin. Electrical alternans is another thing to look for. So this is actually an alternating axis of the QRS complex, which is usually the result of a large pericardial effusion. You can actually see this quite clearly in this example here, and you can see this by the markedly different QRS complexes and the alternating pattern that you see. We've got a large one, a small one, a large one, a small one, and so on. And then finally, we want to look for the presence of something that we call a delta wave. So here's a good example of delta waves. So as you can see with a clear example here, a delta wave is actually a slow, shallow upstroke of the QRS complex. Typically, this is going to lead to having a wide QRS complex and a short PR interval, both of which present in the example that I've got for you here. And this is a classic Wolff-Parkinson-White pattern. So this is where we actually have an accessory pathway that bypasses our AV node, and thus we get ventricular depolarization starting, not originating from that signal coming down those bundle branches. All right, so from here, moving on to step 3, what we're going to be looking at here is our ST segment, T-wave abnormalities, and our QT interval. So we want to take a look at a few more areas that really could show us important information on this EKG. So first, we're going to evaluate our patient's ST segment. And when we're evaluating this ST segment, first and foremost in our mind is that we're looking for possible signs of ischemia or infarction. There are other things that can actually cause these changes, but when we think about the biggest risk to our patient, this is going to be at the top of that list. And in fact, we actually have a whole list of things that we call STEMI mimics that come about that could mimic some of the ST segment changes that would really make us think ischemia or infarction, but in fact are not. So again, I'm going to be doing a whole separate lesson on this topic of ST elevated myocardial infarction, and in that lesson we're going to go into much more detail on all this, but just know that in this step, this is where we want to be looking for this. So for our ST elevation, we need to evaluate all 12 leads for any signs of ST segment elevation, and this is where that ST segment does not return to the baseline isoelectric line. So here's an example of this here. In this example, we have a lateral MI with good ST elevation in leads 1, AVL, as well as in V5 and a little bit in V6. And these are going to be all of our lateral leads. Again, I'm going to link to a lesson that I already did where I covered this information. So if this sounds foreign, make sure you watch that lesson there. But you'll also notice that we do have reciprocal changes where we see ST depression in leads 2, 3, AVF, as well as V1 through V3 we see some. And so when we measure this ST elevation, trying to determine, if we have enough elevation, we do this from something that we call the J point, which is the point right here at the end of the QRS complex. So if we have an elevation above that isoelectric line of 1 millimeter, so one small box, in any 2 contiguous leads, with the exception of V2 and V3, then this is what we would consider ST elevation. So it doesn't take much for us to classify something as ST elevation. Now that said, for leads V2 and V3, instead of 1 millimeter, we actually need to see 2 millimeters. So just some of our potential causes real quickly for now for ST elevation can include things like obviously STEMI, left ventricle hypertrophy can do this, left bundle branch block, paced rhythms, benign early repolarization can present this way, pericarditis, left ventricular aneurysm, coronary vessel vasospasms, as well as severe hyperkalemia, hypothermia, PEs, Brugada syndrome, and Takotsubo cardiomyopathy. Now, we already kind of hit on this a little bit, but in addition to ST elevation, we also want to be looking for ST depression. So here, unlike elevation, we're looking for an ST segment, again measured from the J point, that's below the isoelectric line. So for this, anything that's 0.5 millimeters or more, so half of a small box, and we have this in 2 contiguous leads, that we would then consider this to be ST depression. So some potential causes of ST depression include our non-STEMI. Again, this is going to be the top of our list for concern. Potentially a posterior MI. We might see this when we're looking at our normal anterior view. We're going to see this initially as ST depression in particular leads. Reciprocal changes like we just talked about in the presence of a STEMI in other leads. Left bundle branch block can also do this. Left ventricle hypertrophy with strain pattern can look this way. Digoxin toxicity, hypokalemia, as well as tachycardia can all present with ST depression. All right, so now we've evaluated our ST segment. Next, we want to evaluate our patient's T wave for any abnormalities. So there's actually a lot that could be covered here as well, but for the basics of this, really we want to be looking for T wave inversion and for peaked T waves. So T wave inversion. This is where we have a T wave that has a negative deflection that's greater than 1 millimeter, so one small box. If we have this isolated to either leads 3, AVR, and V1, that this is something that we actually consider normal. As you can see from our example here, we have isolated T wave inversion in AVR, which, like I just said, is something we consider normal. Anything outside of these 3 leads, we would consider true pathologic T wave inversion, and some potential causes of this, all of the same causes of ST depression, as well as elevated ICPs, hypothyroidism, as well as late pericarditis, can all present with these pathologic T wave inversions. Then we also want to look for peaked T waves. And when we're talking about peak T waves, we're looking for enlarged T waves that are typically the size of the QRS complex or larger. So here's an example of some here, particularly if we look at V2 through V5. If we have this going on and we have a narrow base with a tall symmetrical peak, then this is actually most likely going to be the result of hyperkalemia. If you remember that memory mnemonic of hyperkalemia, we're looking for peak T waves, we're going to see this with a narrow base, tall symmetrical peak. In our example here, that's actually what we see. Now, if we do have peak T waves, but we've got a wide base and we've got an upsloping or asymmetrical peak, that this could actually be the sign of early STEMI before we begin to see those ST elevation changes, as well as we can also see T waves that look like this with vasospasm. All right, so after evaluating our T waves, finally we want to evaluate our patient's QT interval. And this is going to be the start of the QRS complex to the end of the T wave. This raw measurement, though, doesn't actually tell us a lot, as our patient's QT interval is often going to change based on their heart rate. So faster heart rates are going to have shorter QT intervals, and so really what we need to do is correct the QT interval for the heart rate, something that we refer to as QTC or QT corrected. So this is done in a few different ways, and as we can see here, the EKG actually does the calculation for us as well. One quick rule of thumb when we're evaluating our patient's QT is to take 2 consecutive R waves and then find the halfway point between them. The halfway point is going to be a QT corrected or QTC of 500 milliseconds. The preceding T wave should conclude before this halfway point. So a normal QTC for men is actually considered to be less than 450 milliseconds and less than 460 milliseconds for women. That said, generally greater than 500 milliseconds is really when many consider this to be clinically significant, and thus our general eyeball rule of thumb is good for evaluating this. The big concern that we have for an elevated or enlonged QT interval is that the patient is at risk for R on T, so this is where we have a QRS complex that falls on a still depolarizing ventricle, a T wave, and this could lead to torsades, as well as the patient being at risk for long QT sudden death. So potential causes for our prolonged QT, this include things like our congenital long QT syndrome, hypothermia. Various medications can prolong this. This includes certain antiarrhythmics, antibiotics, antidepressants, antiemetics, as well as antipsychotics. So think of a lot of our antis in here, that these potentially have medications that can also prolong this QT interval. As well as we can see this with hypokalemia, hypocalcemia, hypomagnesemia, as well as hypothyroidism. So again, here think of all of our hypos. These are all potentially things that could lead to prolonging this QT interval. All right, so having done that, we have gone through all the different steps and looked at all the different parts of the EKG. Now, obviously, we went through some of this stuff real quickly here. Like I said, I'm going to have on some of this stuff, actually a lot of this stuff, I'm going to have individual lessons where we can break this down in more detail. But this is the general overview process that you want to go through. So again, this is just one example of one systematic approach. The important thing is that you find one approach that works for you and that you stick with it, religiously go through each and every step when you're evaluating an EKG. This way, when you're going through, you're not going to miss a single thing. So I really hope this was good information for you guys. Make sure and stay tuned for those future lessons where I'm going to dive even deeper into these different topics. So hopefully that by the end of this entire series, you guys should be pretty comfortable when it comes to looking and evaluating your patient's 12-lead EKG that you get in the ICU. So again, my goal isn't to make you as competent as a cardiologist. That's certainly not expected nor even needed. But it is important that you're able to look at this and quickly see some things, confirm with what the EKG is telling us as well, and be able to get people's attention to that quickly when needed. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.